Okay, protocol 29 is our allergic reaction anaphylaxis adult protocol. And it's broken down between your symptom severity. Are they mild, moderate, or severe? So for our mild allergic reaction patients, treatment will start with the advanced provider administering diphenhydramine at 25 to 50 milligrams IV or deep IM. For our moderate reactions, our EMTs can administer the EpiPen and albuterol without a prescription. Albuterol 2.5 milligrams in 3 mLs times 3 as needed. Our advanced providers, if they have not already given the diphenhydramine, will do so at 25 to 50 milligrams IV or deep IM and administer epinephrine 1 to 1,000, 0.3 to 0.5 milligrams IM. Also, our IMP level providers will have methylprednisolone or solumedrol, and that is given at a dose of 125 milligrams IV or IO. Now we move on to our severe anaphylaxis or allergic reaction. Of course, if not already done so, the EMTs will administer the EpiPen and albuterol, same as in the moderate reactions. The advanced provider will administer the epinephrine, again 1 to 1,000, 0.3 to 0.5 milligrams IM every 5 minutes, and they can repeat this once, as well as diphenhydramine 25 to 50 milligrams IV or deep IM. Now our IMP level providers will administer the methylprednisolone or solumedrol at 125 milligrams IV or IO, and we have a new administration technique for epinephrine, and it's epinephrine 1 to 100,000. And that is 1 milliliter a minute for 10 minutes, IV or IO. Okay, so how do we get this epinephrine 1 to 100,000? Well, this is basically taking the place of epi infusion. It's a little bit simpler to do. If the patient does not respond to epinephrine IM and fluid resuscitation, IV epinephrine should be administered. So how do we do this? We take a Bristojet of epinephrine, a 1 to 10,000. What we're going to do is waste 9 mLs from the Bristojet. So that leaves us with 1 ml of 1 to 10,000 epinephrine. You're going to attach this Bristojet to the tubing, pinch the patient's side of the tubing, and draw back. What we're doing is filling that Bristojet with normal saline. So now we have 10 cc's or 10 mLs inside your Bristojet, and 1 ml was epinephrine 1 to 10,000. At this point, we have epinephrine 1 to 100,000. You're going to administer 1 ml a minute for 10 minutes. Protocol 30 is our allergic reaction anaphylaxis pediatric protocol, and it is broken down between mild, moderate, and severe. Okay, so for our mild allergic reaction for pediatric patients, our treatment starts at the IMP level with diphenhydramine at 1 milligram per kilogram IV or deep IM. For our moderate and severe, our EMT through paramedic, the EMT is going to administer that epinephrine auto-injector. If the patient is greater than 30 kilograms, they're going to give the adult EpiPen. If they're less than 30 kilograms, EpiPen Junior. They're also going to administer albuterol, 2.5 milligrams nebulized, and they're going to repeat as needed times 3. And that can be given by our EMTs and our advanced providers without a prescription. Now, at the IMP level, we're going to administer the epinephrine 1 to 1,000, 0.01 milligrams per kilogram IM, max dose of 0.3 milligrams. Diphenhydramine 1 mg per kg IV, IM, or IO. Solumedrol 2 milligrams per kilogram IV, IO to a max of 125 milligrams. And of course, our normal saline boluses of 20 mLs per kilogram. You may repeat to a max of 60 mLs per kilogram, so we may give 3 saline boluses. If no improvement, we are going to go to the epinephrine 1 to 100,000, and we're going to administer 1 milliliter per minute, same as the adult. Okay, protocol 31 is our altered mental status protocol, and again, this is really just used as an assessment tool. This protocol, every terminal point of this protocol asks you to exit to the appropriate protocol. No real change from your current treatments. Protocol 32 is our bradycardia adult protocol. Again, no real change from your current treatments. Still at the IMP level, considering atropine at 0.5 milligrams IV-IO, may repeat 3 to 5 minutes, as well as transcutaneous pacing, early and second and third degree AV blocks. Also consider dopamine, 5 to 20 micrograms per kilogram a minute if no clinical response. Of course, this is for patients' heart rates less than 60 beats a minute and symptomatic, which includes chest pain, difficulty breathing, altered LOC, or signs of hypoperfusion. Again, before pacing, we want to consider sedating our patients with Versed at 2 to 4 milligrams IV IO. Okay, protocol 33 is our bradycardia pediatric protocol, and this protocol is heavily based on bradycardia causing hypotension, altered mental status, and poor perfusion or shock. If the answer to that question is yes, then we need to assess the airway of our patient. Pediatric patients generally go into arrest due to airway problems, so if we do not have a patent airway and the patient is not oxygenating and ventilating properly, we need to exit to the airway protocol and secure an airway. If they are oxygenating and ventilating adequately and have a patent airway, then we need to consider underlying causes. And of course, we need to get a blood glucose analysis in our assessment, obtain IV access, and ECG. Okay, so if they continue poor perfusion or shock, we need to start with our normal saline boluses of 20 mLs per kilogram IV IO, repeat as needed times 3, and we're going to go to our epinephrine 1 to 10,000. The dose is 0.01 milligrams per kilogram IV IO. We may repeat every 3 to 5 minutes. All right, so if increased vagal tone is the cause for the bradycardia, then we will consider atropine. Dose is 0.02 milligrams per kilogram IV IO, minimums of 0.1 milligram, and you may repeat in 5 minutes one time. Also consider external cardiac pacing. Of course, if we do have a suspected beta blocker or calcium channel blocker overdose, we want to refer to the overdose poisoning toxic ingestion protocol for pediatrics, and that is protocol 44. Protocol 34 is our cardiac chest pain protocol. Okay, so for our cardiac chest pain protocol, all provider levels will be acquiring a 12-lead ECG and administering aspirin, 324 milligrams, or 481 milligram tablets chewable. They will also be administering nitroglycerin, sublingual at 0.4 milligrams, every 5 minutes times 3 as needed. Of course, maintaining a systolic blood pressure greater than 90 millimeters of mercury. They can use the patient's prescribed nitro or the nitro that's in the BLS drug box. Our advanced through paramedic level providers are going to be administering the nitroglycerin sublingual as well as nitro paste. Maintaining a systolic blood pressure greater than 90 millimeters of mercury, they will administer 1 inch of the nitro paste. Also, normal saline boluses as needed, 250 mLs up to 1 liter. Now for the I and P level providers for pain, we'll be administering morphine, 2 to 5 milligrams IV IO, or fentanyl, 1 microgram per kilogram, IV IO, IM, or IN. And also for hypotension, if needed, dopamine, 5 to 20 micrograms per kilogram a minute, IV IO, to maintain a blood pressure. Okay, protocol 35 is a dialysis renal failure protocol, and this is based heavily on if any of the following are present: hemodialysis in the past 4 hours, serious signs and symptoms, systolic BP greater than 89 millimeters of mercury, and a blood sugar between 69 to 249. If the answer is yes, then we are going to assess the patient's ECG. We're looking for peak T waves and that wide QRS greater than 0.12 seconds. If these are present, we're going to administer the calcium chloride 1 gram IV IO over 3 minutes and sodium bicarbonate 1 milliequivalent per kilogram IV IO. So just a few notes on this: do not take BP or start IVs in extremities which have active working shunts or fistulas in place, and always consider hyperkalemia in all dialysis and renal failure patients, and we see this by peak T waves and wide QRSs. IMP level again for the treatment: calcium chloride 1 gram IV IO over 3 minutes, sodium bicarbonate 1 milliequivalent per kilogram IV IO.